Good afternoon, everybody. To those of you in person and on Zoom, it is my great pleasure to introduce Dr. Raghav Sundar, who will be the speaker this afternoon. He is an associate professor here of medicine and medical oncology and is one of our newest faculty members. And are thrilled that he decided to come join us at Yale. So his focus is in caring for patients with GI cancers, specifically patients with upper gastrointestinal cancers and peritoneal surface malignancies. He earned his Bachelor of Medicine and Bachelor of Surgery from the National University of Singapore, where he also completed his PhD. And he underwent fellowship training at the Drug Development Unit at the Royal Marsden Hospital in the UK. And he will be talking to us today about charting gastric cancer evolution through tumor ecosystems and metastatic pathways. And we are pleased that you'll be speaking to us today, Raghav. Thank you.
Thanks, Pam, for that really kind introduction, and it's really an honor and pleasure to be able to give the grand rounds today. And thank you for everyone making the effort to come here in person, despite the obvious notices of not getting lunch. So these are my disclosures. So as Pam mentioned, I come from Singapore, which is a small but prosperous city-state in Southeast Asia. And it's known for many things, but one of the things it's really famous for is its food. And this is a dish that we really enjoy in Singapore. My kids and I, it's called a dish called nasi lemak, which is a coconut rice dish with different condiments that are given together with it. And of course, McDonald's decided to create a nasi lemak burger. And this is actually what my kids enjoy more than the nasi lemak itself. So every month or so, we'll go down to McDonald's and have this. And now about 8 months ago, we took the world's longest flight from Singapore to JFK and landed in New York. And then the kids were like, we want to go to McDonald's. And then we were like, okay, let's go to McDonald's. And they were pretty shocked to find out that the nasi lemak burger wasn't available over there. And for folks who aren't aware, actually, McDonald's makes an effort to try and create local sort of dishes in each country that it sets up in. So like in India, you get the Maharaja Mac. And in Southeast Asia, you get these satay burgers, which are usually not available in other countries. And so today, I'm going to talk to you a little bit about how tumors that start from a certain site would need to adapt to the places that it lands in, and similar to what McDonald's has been up to. So again, as a disclaimer, today's talk, given the breadth of the audience, I'm going to try to keep it somewhere in the middle between clinical and science. And so for the folks who are deep on one end, please don't get too bored with some of the very basic descriptions that I'm going to give. Again, for those who aren't familiar with gastroesophageal cancers, it's actually a leading cause of morbidity and mortality globally. It's the fifth most common cause of cancer worldwide, and also now the fifth most common cause of cancer-related death as well. There is an Asian preponderance for the illness, mostly occurring in China, Japan, and Korea. But we do have pockets of increasing incidence of gastroesophageal cancers, particularly in South America, in Chile, as well as Eastern Europe. And even in the United States, in certain pockets, we do see increasing incidences, again, in the early onset, which is something that's of a lot of importance to a lot of us managing these patients. And if you think of the way gastric cancer evolves, there are two types of gastric cancer most of the time that we talk about. One has a very stepwise evolution from normal gastric mucosa that is triggered by Helicobacter pylori to lead to atrophic gastritis, intestinal metaplasia, dysplasia, and then what is usually the intestinal subtype of gastric cancer, which again is more common in the Western population. And there is another, oops, we lose. Okay. There is another subtype of gastric cancer called the diffuse subtype of gastric cancer, which is more common in Asia, and we don't really understand the mechanisms that lead from this. We think there might be H. pylori involved with this as well, but it's not a direct association that is known with the intestinal subtype. And one of the things that there are multiple folks working on is this concept of intestinal metaplasia that is triggered by Helicobacter pylori, which actually leads to the formation of intestinal subtype of cells that are seen within the stomach lining, things like goblet cells and Paneth cells, which you normally don't see in the stomach lining. When you start to see that, then you think of intestinal metaplasia, which is a precursor lesion to gastric cancer itself. And separately, while we talk about the formation of normal epithelium forming into cancer, we also have to start thinking about how the cancer starts as localized disease and as a primary tumor, often through blood vessels, then has metastatic spread. But it's not necessarily the whole tumor itself that is spreading, but it's possibly specific clones that are leaving the primary tumor and landing in metastatic sites. And this is going to be a concept that I'll be touching upon in different aspects of the talk. And it is this differential clonality within these metastatic sites that might actually determine prognosis as well as responses to therapy that has become an area of much needed research and interest over time. And what then happens is, as we treat metastatic disease, either with systemic therapy or radiation therapy, is that therapeutic resistance does occur either through clonal selection or through the persistence of certain clones that have resistance to these therapies. And then this forms the next barrier of tumor evolution that needs therapeutic choices to be made for. The other aspect that's taking a lot of importance in today's areas of cancer biology, we had multiple talks at AACR this year talking about the tumor microenvironment, is that beyond just the tumor cells, which has been the primary focus of a lot of research over the past 20 to 30 years, we are going beyond the tumor itself into understanding other aspects, the microenvironment, which is typically the immune cells and the stromal cells that are surrounding the tumor, but the macroenvironment itself, which includes aspects within the human body itself that leads to either pro-tumoric factors or actually oncogenic progression itself, such as inflammation, thrombosis, as well as cachexia. And of course, the general global environment that we live in and those risk factors that lead to oncogenesis itself. And so as we start to tease out that it's not necessarily just the tumor cells that are leading to what cancer causes problems, the way in which we study the microenvironment becomes important, and I'm going to talk a little bit about that next. The other aspect of specifically gastroesophageal cancers is the heterogeneity that we face. If you remember the normal gastric mucosa that we talk here, there are multiple cells, there are multiple cell types that are present within the gastric mucosa itself, like the stem cells, the chief cells, the parietal cells, and the endocrine cells. And because this is such a heterogeneous mix, even in the normal mucosa, this has been hypothesized to be one of the reasons why gastric cancer itself is an extremely heterogeneous disease when it occurs. There's still a lot of theories around, is it a single one of these cells that has gone rogue and become cancerous and then spread to form the primary tumor? Or is it a trigger that's leading to multiple cells here becoming oncogenic on its own, and that's leading to heterogeneity? And we don't have clear answers to this, but some of the work that we have done now starts to open our understanding of this a little bit better. So a little bit of oncology 101 here is that the first step in understanding the first step this understanding is how we understand cancer itself. And for this, I'm going to use the example of the Singapore underground system. And if you think about this is similar to the New York subway system or the London subway system. It's a very complex network of different train systems that connect at different nodes. And if you actually need to get from one point to another, you have to have a very clear understanding of the different places in which there are interchanges, the different lines that one needs to take and change to be able to get from one place to another. Now, let's replace this or think of this as a tumor, right? If you're giving chemotherapy, you probably don't need to understand the intricate systems that are occurring within the tumor, and the chemotherapy is just nuking the entire system itself. But if you move to the next generation of therapeutics that we developed, which is targeted therapies, a lot of the targeted therapies actually were developed from the concept of DNA sequencing, which is the first way in which we started to understand tumors. And with DNA sequencing, the main focus of analyzing the tumors is the tumor cells themselves. You cannot read anything into the surrounding microenvironment from the DNA sequencing. And of course, you might get a sense that, hey, this tumor is actually using this pathway and growing faster. And so targeted therapies very often just aim at hitting that one big pathway that the tumor is using. And that's the whole concept of targeted therapies. But the problem with this is that we often forget that without understanding the things that are surrounding it, there are probably alternate pathways that the tumor can take. And this leads to therapeutic resistance that occurs in targeted therapies, which we very often see is the general theme is that targeted therapies are not curable because there are alternative pathways that are taken. And so that's kind of why the importance of the tumor microenvironment comes into play. And we now know that apart from the tumor, there are other components that we need to pay attention to, things like the T cells, the immune cells, the tumor vasculature, the stromal cells, the extracellular matrix. All these play a role. And the question now starts to arise on what do we need to know about the tumor and microenvironment? How do we obtain this information? And what are the different assays that we can use to now start querying this? So going back to the Singapore train systems analogy, the earliest ways in which we started to understand the microenvironment is through bulk RNA sequencing. We just take the whole tumor up, grind it up, extract the RNA, and then sequence it. In bulk RNA sequencing, you don't get a lot of granular information about the tumor microenvironment, but at least you get a sense of, hey, there are 3 or 4 different cell types that are there in the tumor. There are T cells, there are B cells. These are the proportions. Analogous here is you at least know there are 5 or 6 different types of lines. There's the red line, the green line, the purple line, and that's about all the information you can get from bulk RNA sequencing. The next generation is single cell RNA sequencing, where not only do you don't just take the whole tumor and grind it up, you actually dissociate them out into single cells, barcode them, and sequence each of these single cells. This gives you a little bit more granularity about the tumors. Not only do you get cell proportions, but you can also get cell states. And what cell states means that beyond just knowing how many different types of lines are there in the train system, you can even get a sense of, hey, actually the red line has 30 stops, blue line has 25 stops. And you get more details of these are the different names of the different stops that you have in the different train lines, right? But the problem with this is that you still don't get a geographical annotation of the tumors based on single cell sequencing. And so the latest generation of profiling that we use is called spatial profiling, where you maintain the tumors with their geography, extract the RNA while they're maintained, and sequence them. That allows you to not only know the cell states and cell types, but also geographical sort of distances between the tumor cells and the immune cells, tumor cells, the microenvironment. And those might start to play a bigger role as we start to tease out therapeutic targets that are not necessarily sitting on the tumor cell, but are actually sitting in the microenvironment, which is the whole new generation of therapeutics that we're developing now. So about 5 years ago, I was sitting with my daughter, and she was eating her M&Ms and coloring her coloring book, and I was just watching her. And being the nerd that I was thinking, is gastric cancer more M&Ms or crayons? And while I made this slide, my daughter highlighted to me that those were color pencils and not crayons, by the way. But the question I asked myself was, when you talk about the heterogeneity that you see in tumors, is the heterogeneity this sort of M&M kind of heterogeneity where it's just different cells all mixed up with each other? Or is it actually, is there a gradation with the heterogeneity that's occurring? Are there different aspects of the tumor itself that are different from each other? Is there a spatial co-localization to the heterogeneity, and does that make a difference at the end of the day? And so to answer this question, we perform a study that involved various aspects of the multi-omics that we talked about. We took about 200 over samples from over 100 patients. we performed spatial profiling on a bunch of samples. We also did single cell sequencing on some samples and then created a tissue microarray on which we did more spatial profiling as well. And I'll entail with you what this sort of study did. So essentially what we did with the nanostring geomics platform is that on each tumor, you can use different immunohistochemical stains to at least mark out the stromal components, which is like this cyan color, with the tumor components or the epithelial components, which are marked by cytokeratin. And then under a deeper, a higher zoom with a microscope, you could also see immune cells that are marked with CD45. And then we marked out specific components of each tumor with regions of interest. Each region of interest is about 600 microns and has about 200 nuclei in it. And we laid out tumor regions of interest, stromal regions of interest, tumor stromal interface regions of interest, lymphoid aggregates, intestinal metaplasia. Each of these regions of interest were marked out manually with the pathologist. And then within each region of interest, we extract the RNA, sequence it to understand what the gene expression programs that are expressed within each region of interest expresses. And what became very clear very quickly was that just within the tumor regions of interest, we could pick up the heterogeneity very quickly. We could see multiple tumor ROIs actually showing different gene expression programs. But what was also very obvious was there's a clear spatial co-localization of the heterogeneity that was seen within each of these tumors. Simply put, you can see that the blue dots are all sitting together while all the red dots are sitting together here, same story here, similar story here, and similar story here, which means that this is not M&Ms that you're seeing in the tumor. This is clearly a crayon sort of situation where there is a clear gradation of the heterogeneity. Cells sitting on one side of the tumor actually doing different things from the cells sitting the other side of the tumor. Then, because we had each region of interest has multiple nuclei and not every nucleus is coming from a tumor cell, we could look at the microenvironments within each region of interest. And again, what was very clear was based on the gene expression programs that we are seeing within these regions of interest, there was different microenvironmental components that were occurring within these regions of interest, which means, again, simply put, as the tumor cell's behaviors change, its interaction with the microenvironment changes. Either it's attracting or the presence or the association of different microenvironmental components occurring within the same tumor. So you're seeing different proportions of B cells, T cells, NK cells, plasma cells, macrophages. You're seeing different proportions of them, but these proportions actually correlate to the gene expression program. So this is not a stochastic sort of vision of the heterogeneity that you're seeing within the tumor. Next, because the depth of the reads that we get on spatial profiling is not that high, you see only about 500 to 2,000 genes, 300 to 500 genes on spatial profiling. On single cell sequencing, we can get a much greater depth of sequencing per cell, up to about 4 to 5,000 genes. And so in our single cell data set, we then went on to ask questions about, could we look at the clonal evolution of the tumor within the single cell data set itself to understand, is there a stepwise progression of the tumor cells from one cell to the next? Or is this, again, a stochastic burst of chromosomal abnormalities or copy number changes that we are seeing within the cells? And again, in this, it became very clear that there were two separate types of evolution that we were seeing within tumors. There was one set of tumors that had a very stepwise change of copy number gains and losses within the chromosomes that we were seeing, with some divergence at later points in time within these cells. Whereas there was another set of tumors that had a very clear burst of differential expressions of copy number changes and losses within these cells that led to a different sort of branching, what we call as a diasporic branching of the evolution that occurred quite early on itself. And this actually had a prognostic difference within this. The tumors that had this had the branching evolution actually had a better prognosis compared to the tumors that had the internal diaspora sort of evolution. And we were able to validate this into other larger data sets like the TCGA, as well as an Asian data set, that the way the tumor evolves actually determines the prognosis or the aggressiveness of the tumor itself. And similarly, again, the tumor microenvironments that were detected within these two tumors were different, with different components and compositions of the different, the fibroblasts, the macrophages, B cells, T cells were actually different between these two different types of evolution. And lastly, as a part of this study, we also studied the tumor stromal interface, which was pathologically defined as a specific zone that we were interested in. And what was quite curious about this was that the gene expression programs that we identified within this zone were actually quite different from the tumor zones and the stromal zones. And the kind of things that were happening in here were quite different. We found a couple of therapeutic targets that we thought might be something of interest because this is where the tumor is actually interacting with the stroma as well as the microenvironment. And this might become the next frontier of therapeutic vulnerabilities that we should be studying about. So this was a paper that, this was a paper that we published in Cancer Discovery a couple of months ago now. All right, so next question was, is gastric cancer M&Ms or balloons, right? So the question that we asked here was, and this is actually a concept that has been evolving. This is a concept that has actually been talked about within this community a fair bit, is that there's always a question of, is the tumor evolution associated with metastatic randomness? And that's basically the concept of the balloons concept. Is just different cells just floating around and landing in different places and causing different problems? Or is there some selective pressures that are being applied that leads to certain cells within the tumor actually landing in different points? And so this principle actually goes back to this concept of the rate of the seeding as well as the selective pressures and the landing sites. And this possibly determines the randomness that's occurring here. So for example, in a lymph node, the theory is that there is actually very low selective pressure, and therefore the kind of clones that land up in the metastatic lymph nodes might actually be quite similar to the primary tumor. This might be actually quite different from a liver metastases, for example, where there is quite high selective pressure in terms of the capabilities of the primary tumor leaving the primary organ, getting into the bloodstream, and then landing up in the liver, having capabilities of actually catching onto the liver and then growing there. And based on different organs, this difference in selective pressures as well as landing sites may change. And there are different groups that are trying to figure this out for different primary tumors. One of the biggest studies was published from the Memorial group, Sloan Kettering group, that had a Cell paper looking at more than almost 100,000 samples of metastases. But one of the things that was missing from this data set that we were quite interested in was actually peritoneal metastases, because this is an area of high unmet clinical needs in terms of this occurs quite commonly in gastroesophageal cancers as well as colorectal tumors. And the peritoneal metastases behave quite differently from other types of metastases. So just to give those folks who aren't familiar with this space, is that for peritoneal metastases to occur, very often the primary tumors will need to leave from the serosal surface of the tumors, get through the peritoneal cavity, and I'll show you another picture of what the peritoneal cavity is about, and then land into the peritoneal the visceral peritoneum or the parietal peritoneum, and then catch on. And this process of metastatic spread was something that we were interested in. So the peritoneum itself is a single cell layer that actually covers all the intestinal organs, including the liver, the small bowel, the large bowel, as well as the lining of the abdomen, kind of forming a protective environment within which these organs are able to slide and move around each other and function normally. There are quite a lot of interactions that occur between this single mesothelial cell layer and the basement membrane with the underlying extracellular matrix and collagen that's present, as well as the immune components within the normal peritoneum itself. And so in this study, we actually looked at multiple questions, mostly asking questions about, are there mechanisms that determine a primary stomach tumor leading to landing in the liver or landing in the peritoneum, and whether there are changes that occur with intraperitoneal therapeutic pressures that are given to these peritoneal tumors themselves. So in this study, we looked at primary tumors and followed them up for peritoneal metastases, as well as those patients that developed these peritoneal metastases where we got these peritoneal samples, and we then subjected them to whole exome sequencing, bulk RNA sequencing, as well as spatial profiling. In this study, we had about 300 patients and about 500 samples. We were able to figure out certain molecular predictors of peritoneal metastases from the primary tumor. Some of the clinical predictors that were known and recapitulated in our data set was the higher tumor stages, higher nodal stages, as well as the diffuse subtype of gastric cancer, which is known to have a higher propensity for peritoneal metastases, was predictors of peritoneal metastases. But in the genomic analysis, we were pretty disappointed to see that we only picked up a few genes that predicted for this, one of them being CDH1, which is a cell adhesion protein. And so then it went back to this question of it is very, very much more likely the tumor microenvironment that is possibly leading to the peritoneal metastases itself. And this was, again, quite obviously seen in the RNA sequencing data that we did, where we could understand the tumor microenvironment, that the tumors that had a propensity to metastasize to the peritoneum had very different gene expression programs and tumor microenvironment components compared to those that didn't metastasize to the peritoneum. In terms of therapeutic targets as well, being a clinician, we looked at the differential expression of therapeutic targets between primary and peritoneal metastases, and multiple important therapeutic targets such as Claudin 18.2 and FGFR2. We saw clear differential expressions of these targets between the primary tumor and the peritoneal metastases, which might explain the reason for the resistance of systemic therapies to these peritoneal tumors, as they were actually expressed at a lower rate in the peritoneal tumors. But of scientific interest, actually, one of the theories that we had was that in order for the primary tumor to land into the peritoneum, there had to be some sort of preparation of the peritoneal lining that had to occur in order for these primary tumors to land there. And this is what we defined as the pre-metastatic niche. And in this study, because we had the capability of doing spatial profiling and actually tease out the stromal components and the tumor components within both the primary tumor and the metastases, what we found quite interesting was that there was a convergence of the stromal components of the primary tumor and the peritoneal metastases, something that we didn't, we predicted, didn't expect to see, but ended up seeing, is the fact that the stromal components of both the primary tumor and the peritoneal metastases actually started to look quite similar. So this idea or concept that there was some pre-metastatic niche formation was starting to, that hypothesis was starting to formulate over here. And so we actually then went on to take benign peritoneum from patients going from appendectomies and cholecystectomies, and we compared them to peritoneal tumors, peritoneal linings of primary tumors without peritoneal metastases, and you could see that there was a clear gradation and a separation of the inflammatory sort of findings that we were seeing in peritoneal metastases, as well as benign tumors with full-blown appendicitis with inflamed peritoneums, as compared to those going for elective cholecystectomies that didn't have peritoneal metastases. Again, adding additional sort of layers of information that there is probably an element of peritoneal priming that's occurring here. And we then validated this in a mouse model. For the interest of time, I'm not going to go into too much of details here, but this was something that we did. It was quite an elegant study where we took primary tumor cell lines that had known propensity to metastasize to the peritoneum, put it into the flank of the mouse in a group, put it directly into the stomach of the mouse, and then in another group, put them into the peritoneum, eventually harvested all these tumors and compared them to show that this concept of peritoneal priming was occurring with these tumors as well. So this was a study that we published in Gastroenterology about 6 months ago now. So the next question we asked was, is this whole concept of niche reprogramming something that's unique to gastric cancer, or does this occur in other tumor types as well? And so on a parallel study, we also studied colorectal cancer and peritoneal metastases. In this study, we took about 50 over primary colorectal tumors, 120 colorectal peritoneal tumors. Again, similarly performed whole exome, whole transcriptome, and spatial profiling. And we were able to show a similar principle of niche reprogramming that was occurring in the colorectal cancer space as well. And this hypothesis that this is not just unique to gastroesophageal cancers, but probably true for any GI malignancy with a propensity to metastasize to the peritoneum. What was nice about this study was that because we had a larger data set of peritoneal tumors that we did spatial profiling, we were actually able to subcategorize the stromal components of the peritoneal metastases, where we came up with a differential classification of different stromal subtypes which were there within the peritoneum. And one of the subgroups called SC2, which has a higher proportion of fibroblasts and inflammatory T cells, actually, we were able to create a signature for this sort of stromal subtype that had, again, a negative prognostic factor. But within this stromal signature, we actually identified a single gene that was a putative therapeutic target, bringing back this idea of we are trying to drug these things and not just to do discovery studies. And so we found a target called SERPIN1 or PI1. This is a paracrine factor that's present within the malignant ascites of patients with colorectal cancer and other tumors that have malignant ascites. And we were able to actually develop an antibody that binds to PI1, which actually at least in animal studies or in cell lines, we were able to show that it does actually inhibit malignant ascites. And the theory or the hope is that this is something that can actually be delivered intraperitoneally rather than something that's given systemically for patients with malignant ascites. And so this was a paper that we just published in CCR. It was a simultaneous publication at AACR a couple of weeks ago. And so one of the questions that one might ask, looking at these two, the gastroesophageal peritoneal paper and the colorectal peritoneal paper, was like, hey, actually, you found a very similar storyline in these two tumor types. Did you ever consider putting it all together and coming up with a pan GI sort of proposal that actually this is a phenomenon that is something where, to me, one of the very interesting scientific concepts was this idea that the primary tumor is actually priming the peritoneum. And if we could actually do something to prevent that happening, this might be a nice area of therapeutic vulnerabilities that we can start to address. And some of the work we're showing here actually goes back to this concept that this may actually be true, that now we're showing it across two separate subtypes. The truth of this whole journey that we went through was that that was the initial hypothesis that we came in. This looks like two separate studies and two separate papers, but the truth is we actually were planning to do one big pan-GI paper that took 2 or 3 years to go to be formed. We had this concept of primary tumor and tumor microenvironment, primary tumor and metastatic convergence of the microenvironments. And that paper just died in peer review over and over again. We went to every single big journal and just died. So at the end, we gave up on that concept and split it out into two separate papers. And then it finally got published. And then 2 weeks ago at AACR, Charlie Swanton showed the same story happening in lung cancer. And that was a Nature paper of the convergence of primary tumors and tumor metastatic sites having tumor microenvironment convergence. And then we were like, hey, we came up with this 5 years ago, but nobody heard us. And so that's why I left the land of good food and came to the land of McDonald's. But yeah, I mean, jokes aside, I think that was definitely something that I felt was a part of my life that I wanted to push forward a little bit more, was beyond just the discovery of therapeutic targets, is how do we bring some of this stuff to the clinic? How do we bring this to our patients? At the end of the day, I still consider myself a clinician first. And so the question is, how do I bring this to the clinic? And so the question was, everything that I've talked about so far is great, but nothing's going to help my patient in the clinic tomorrow. When you see a patient with peritoneal mets, in 2 hours, I'm going to run clinic with 5 patients with peritoneal mets, and nothing I've done in the lab so far has helped my patients. And so this is where I think there's a new frontier of therapeutic strategies that are being developed for patients with peritoneal metastases. There are at least 3 different ways in which we are thinking of delivering peritoneal therapeutics. The first one of them is the oldest way in which therapeutics were delivered into the peritoneum, called HIPEC, where surgeons would go in, remove all the peritoneal tumors that were seen, which is called cytoreductive surgery, and then put in heated chemotherapy into the peritoneal abdomen, most of the time as a one-off sort of thing after surgery, to try and kill off any of the microscopic metastatic disease. As you can see, this has its own set of logistical hurdles, because patients would need to be fit enough to go for a major surgery, removal of tumors, and then have the heated chemotherapy delivered in the abdomen. And so a more repeated form of way in which therapeutics could be delivered into the abdomen was being developed. So in Asia, they developed a catheter-based way of delivering the intraperitoneal therapeutics. So a simple port which we use for venous delivery of chemotherapy is put in again by the surgeons into the abdomen. And through this, multiple cycles of chemotherapy can be delivered into the abdomen. And separately in Europe, they developed PIPAC, which is a pressurized mechanism that's attached to a laparoscope that allows high pressure delivery of therapeutics into the peritoneum, with this hypothesis that by putting in the pressure, you actually have deeper penetration into the peritoneal tissue, killing away the tumors. And so now there is a global convergence of these different strategies. Different groups across the world are trying these different things out. Just at ASCO GI this year, about 4 months ago, there was a big oral presentation with a positive study using intraperitoneal therapeutics from China with intraperitoneal paclitaxel for patients with gastroesophageal cancers, which had an overall survival benefit. And in the United States, we are trying to replicate this as well with the Stopgap 2 trial that is looking to open in the near future and enroll across the United States. In Yale, it's also we're going to open this trial where we're going to try and deliver intraperitoneal paclitaxel to patients with gastroesophageal cancers with peritoneal metastases. And so one of the studies that we did in Singapore was this idea that because the peritoneum was generally considered a cold tumor microenvironment, was that could we deliver a therapeutic agent that led to immunogenic cell death into the peritoneum and then kick in systemic therapy separately to try and address this concept. So this was a first in human study looking at intraperitoneal PIPAC oxaliplatin in combination with nivolumab. It was a multi-centered study with 3 sites across, 2 sites in Singapore and 1 site in Belgium. And we gave PIPAC on day 1 and then had systemic nivolumab going in with a second and a third PIPAC available every 6 weeks. This was done in the era where immunotherapy was given in second line or third line and beyond for gastroesophageal cancers, where patients weren't exposed to immunotherapy in front line when we conducted this study. And so what was promising was that we did see some intraperitoneal responses, particularly in patients who we didn't expect to see responses. For example, this patient had a PD-L1 CPS score of 0, had gone through 5 lines of treatment, including systemic immunotherapy before they got exposed to this, had a PCI score of 39 when they first started, but after a couple of cycles, you can see that there's a clear reduction of the PCI scores, clear changes in the peritoneal tumor burden that was seen in these patients. And so as a proof of concept, we were able to show that from a translational analysis that we were able to induce immunogenic cell death, increase tumor infiltrating lymphocytes into these peritoneal tumors. But again, without a strong systemic therapy backbone, with single agent nivolumab, I think the overall survival and clinical response rates weren't as great as we could, we had hoped for. But I think at the end of the day, being here, one of the hopes is with Dr. Turaga, who's the chief of surgical oncology and is a peritoneal surgeon, is that my goal is that rather than delivering chemotherapy into the peritoneum, which I think may not be the best agent, is to deliver a novel therapeutic. And that's the hope, that over the next few years is with translational studies as well as clinical trials, develop a strong enough program that we can start developing these novel therapeutics that we can deliver into the peritoneum. And we do have the ecosystem and expertise now to do this at Yale. And on a separate front is the whole space of gastroesophageal cancer therapeutics itself is absolutely exploding. It's leading the front in precision oncology for GI cancers with multiple new therapeutic strategies that are coming up in this space. One of the good examples is Claudin 18.2, with a first-in-human, first-in-class approval for zolbetuximab, which is an anti-Claudin 0.2 antibody in gastroesophageal cancers, which is rare and nice because most of the time, by the time the drugs come to gastroesophageal cancers, they've been tested in lung cancer or colorectal cancer and then land up in upper GI. This is one of the few drugs that has started with upper GI and then is moving on to other tumor types like pancreatic cancer now. And so what's also exciting at Yale is we now have all the best therapeutic trials that are coming in now. We have Destiny Gastric 05, which is a HER2 positive trial for our patients that's going to be opening soon at Yale. In the Claudin space, we have Lucerna, which is looking at zolbetuximab in combination with immunotherapy for patients who are Claudin 18.2. And in the immunotherapy space, we're looking at continuing immunotherapy beyond frontline for our patients with PD-L1 positive disease, which just opened a couple of weeks ago. And so this is an exciting time for us to be in the space of gastroesophageal cancers. And with that, I'll just like to end by acknowledging my previous institution where I managed to do most of this work that I presented, my PhD mentor and life mentor, Patrick Tan, and one of my favorite mentees who led most of these studies, Joseph Chow. It took a huge group of people to do this work, multiple international collaborations from Italy, Europe, MGH, and a lot of governmental support for these studies. And at Yale as well, I'd like to acknowledge my mentor, Spam, for helping me start setting up the gastroesophageal program here. And with that, I'm going to end my talk and take questions. Thank you very much. Thank you. Okay.
One is related to structure. Another is unrelated combination. Is that does EBV fit into that category? If they does, these two types in terms of response to metastasis, in terms of behaviors for metastasis, or in response to treatment, how they treat.
Okay, so the folks on Zoom, I think the two questions was, what is the role of EBV in the whole tumorigenesis process of gastroesophageal cancers? And the second question was to do with therapeutic resistance with the context of EBV, or was that a separate question? Got it. So I think EBV is certainly an important component of gastroesophageal cancers, has been described in the TCGA. And in the TCGA, they describe it as about 7 to 10% of the total number of gastroesophageal cancers. But the truth is multiple studies have been done downstream and show that the incidence of EBV is not as high as what they found in the TCGA. It's actually much lower, probably in the range of 3 to 5%. So it's a lot rarer than the original thoughts of how much EBV contributed to this. It does form a unique subtype of gastric cancer, and pathologists very often can look at it in the microscope and say this looks like an EBV infiltrated tumor because of the way the tumor infiltrating lymphocytes come into it, forms very unique pathological diagnosis. But even within EBV, we have done some studies show there are two types of EBV positive gastric cancer. One, which is highly infiltrated, high PD-L1 expression, but there's at least about a third or half of that small subgroup that actually look very much like gastric cancer, where we're not sure if EBV is playing an important role. So how much EBV plays in this whole game, not really certain. And because it's quite rare, most of our studies, we've actually tested the EBV and it's all negative. So I actually have very little information from these data sets on EBV. Internationally, we are forming a group that is looking at EBV positive gastric cancer. Actually, that's led by Steve Marone from MSKCC, and they've collected about, I think, nearly 300 to 400 EBV positive tumors, and they are trying to perform some studies there. But it's likely to only address a small subgroup of patients. In terms of the therapeutic resistance and the how much they play from an etiology perspective, the truth is I've had folks interested in Helicobacter pylori biology who have come to us and asked, can you see the H. pylori in the gastric tumor? Do they play a role? And the truth is, as medoncs, most of the time, we don't even care about the H. pylori. We just think that whoever diagnosed it would have treated it and it's done, and it doesn't ever play a role in our treatment paradigms. But to answer that question, we actually went back to look at it. And very often the gastric tumors themselves lose the H. pylori by the time they come to the metastatic stage. I think if it's still at the T1 or the early T2 N0 sort of stages, they may play a role. But once it gets bigger than that, then the H. pylori stops playing a role directly. So I'm not sure how much of the H. pylori-based therapeutic strategies can get integrated into the later advanced tumors and the systemic strategies. Those were questions that were asked in multiple forums, but I'm not really certain of that answer at this point of time. Yeah. Absolutely. So.
Here maybe just 8 and 1 have strategy. The reason I brought this particularly, if you look at the etiology of the gastric cancer, which is show Singapore, food, China, here, with the exception of the Japan, they actually all have high incidence of EBV.
That is true. Thank you.
Any other questions?
Thank you. This is really inspiring work. From a practical clinical standpoint, let me just ask one question. I think it is truly exciting to see this combination of systemic therapy, kind of peritoneal-based regional therapy, coupling that with a surgical approach. As a clinician treating these patients, so I'm always struck by the fact that, at least in gastric cancer, it is not just the peritoneal disease. It is often the intramural lymphatic disease that is very difficult to manage from a clinical standpoint. The patients have the peritoneal disease, but they also have kind of infiltrative disease within the stomach itself and sometimes in the small intestine, which makes treatment really difficult, even if you're getting the therapy into the peritoneum and getting to some of those mets. Will those therapies treat the disease within the wall of the stomach and the intestine to allow patients to start eating again?
Yeah, great question. I think to your point is that at the end of the day, even though we call the peritoneal metastases oligometastatic and surgical resectable and all that, in a large proportion of patients, because of the kind of metastases that's either intramural or stuff that can't be surgically resected, the eventual strategy is going to be a more elegant systemic therapy that's combined with an intraperitoneal strategy. And the hope here is actually by using the intraperitoneal strategies are not necessarily to remove and eradicate everything for all our patients. That might be only a small subgroup of patients where it's upfront the true definition of oligometastatic disease and you're eradicating it, but actually just being able to enter the peritoneum and deliver something that will help potentiate the systemic therapy from working. I think that's going to be the way forward rather than it being solved from a mechanical way of addressing all this. It will have to be a drug that will go into address this. And so that's where the advances in systemic therapy with some sort of local regional potentiator or catalyst of, for a better word, will probably be the way we'll address a lot of those rather than a single time point sort of thing. Yeah.
We have one question from the Zoom room. Thanking you first for your talk. And then, did you see the recent developments in therapeutics of upper GI cancers eliminating the need for surgical intervention in the nearby future? And then a sort of second follow-up question, will age and or other patient demographics play a role in these upcoming trials?
Thanks for the question. I think that's a hot topic at this point of time. The truth is that while these new therapeutic strategies seem quite exciting to us, from a non-operative approach, even if you use the less chemosensitive tumors like rectal cancer, for example, not even talking about other tumor types that are just within the GI space, you are getting clinical complete response rates of around 50-60% for us to even start talking about non-operative approaches. But in upper GI cancers, we're not even close to that. Like even with the best treatments, if you look at FLOT plus durvalumab, the Matterhorn, which is going to be a plenary, we know the PCR rates were only around 20% in these patients. In the Western population, maybe 30%, but it's still far from the 50% kind of rates that we need to start talking about non-operative management. So I think we're still a little bit away from getting to non-operative. We are getting there. Maybe something like a trastuzumab plus immunotherapy plus chemotherapy sort of combination approach. If you're starting to get to the 50-60% response rates, CCR rates, maybe we'll get there. But it's still a lot of work, I think, for us to be able to be talking about saving patients, a large proportion of patients. I'm not talking about the mismatch repair. That's a separate subgroup. But everybody else, I think we're still a while away. Separate to that, I think in terms of the age and other demographics, that's always been an important question. These are very often not going to be answered in the seminal trials that are being done in these spaces, but more likely to be cooperative groups and others answering some of these questions. A lot of the questions here are things like escalation or de-escalation of these therapeutics, especially age dependent. There are some talks about whether we can give FLOT to more elderly patients or reduce the intensity of FLOT, but still keep FLOT going on for poorer performance status. And those are the kind of questions that are being bounced around at this point of time within the cooperative groups to try and run some of these trials. And so I think these are important questions to answer, but probably won't, it'll probably just be a subgroup analysis for the seminal trials. Yeah.
Any other questions? Raghav, I have one. I know when you were considering coming here, we were talking a little bit about the shifting demographics in the state of Connecticut and that Asian population is one of the most rapidly growing populations. Can you speak to that and how we're thinking about that in terms of screening, potentially therapeutics, and even just even outside of Connecticut nationally?
Thanks. Yeah, so I think there are a couple of things that the numbers are not, the population level numbers are not keeping up with what we might actually be seeing on the ground. It does take a couple of years for some of these data to show up as a more sort of statistic. Is the early onset GI cancer component, which is something that is more reported in the colorectal and pancreatic cancer space, is something we're certainly seeing in upper GI cancer as well. Even in my own clinic, we're very often seeing the 20, 30, 35-year-olds who are coming in and not hereditary, not CDH1 driven tumors that we're seeing. So this is something that is just as a feel, you can see the early trends of this happening in some of the papers, but it's not the kind of level that you're seeing in colorectal cancer. But I think it's also happening in upper GI cancer space, which we know that the early onset patients generally take a lot more sort of, they need a lot more support in terms of they're right in the middle of their careers. There's a lot of disruption to the work, the disruption to life, work, everything else that makes it hard to add on multimodal therapy for these treatments. So there's a definite set of resources that we need to start thinking of ring fencing for these groups of patients. Separately is more than a rise of a certain demographic in a certain part, I would say, is just this general globalization that's occurring, that there are just different subgroups of patients moving across the world, even if they're staying in a certain place for a few years. This concept of a higher incidence of a certain tumor type in a certain region has sufficient overflows that are occurring in other places. So we very often in the clinic are seeing folks who are not necessarily here long-term or haven't lived here long-term, but are getting diagnosed with a lot of the upper GI cancers that require emergent treatment and things like that that we need to consider. Separate to that is this whole concept of the fact that a lot of the therapeutic strategies that are being developed for upper GI cancers are still being, the initial developments are still occurring in the United States compared to Japan and Korea, where very often they're taking on the next degree of novel therapeutic development, but the first in human sort of drugs are still the ones that are being developed here. So this still forms an area that we need to pay attention to, given that upper GI cancers is almost forming its own niche, similar to HCC, for example, where the therapeutic strategies are diverging quite differently from colorectal and pancreatic cancer, for example. Did that answer some of the questions? Yeah.
If there aren't further questions, I'd really like to thank you for the talk today, but also we are so grateful that you are here. I know that the gastroesophageal cancer program will really thrive under your leadership. So thank you.
Thank you very much.